Welcome back. This is EKG Clinical Vignettes, high yield review for the COMLEX and USMLE. Some of the feedback I got from the video series, and I absolutely agree with this, is, reading EKGs is great, but what you really need to do is learn how to put it to practice. And in the case of your medical students, health professionals, we actually need to put it to practice in terms of your licensing exam questions. So, the idea behind this is that we're going to go through a series of cases, and we're going to talk a little bit about EKGs, but we're also going to talk about how that applies to different etiologies, different forms of treatment, things that you might actually see on your examinations. And so I'm hoping this is very high yield and we can really put the pieces back together. Now, importantly, disclaimer, okay, if there is a rhythm or something that you do not understand and you need more information about that, I highly recommend going back to your introduction series and looking at the specific rhythms related to where your confusion is. This is not going to teach you every single little detail about every little rhythm like we tried to do back in the original videos. I'll also give a little disclaimer. We're gonna go through at a pace. If you need more time, just pause the video at any point and take the time that you need to do that. We're gonna record this in 3 parts, but I hope this is very helpful, and let's get started. All right, you have a 76-year-old man with hypertension, and he presents with sudden right arm weakness. So already you're thinking of some differentials, hopefully, in your head of what this might be. But you get this EKG. What do you notice? Okay, now that you have that in your head, what do you think the most likely cardiac rhythm is? Yes, perfect. It's atrial fibrillation. And why do we know that? If we look at our EKG, what's one of the first things that, maybe your eyes are drawn to? And I really hope you're looking at this rhythm strip down here and you're seeing that these points here are not equally distanced apart. We have a variable R to R ratio. We know that this rhythm therefore is irregular. And if we look, there's no pattern to it across time. So it's irregular. And when you hear that, I want you to just channel the energy from all the EKG gods and know that this is atrial fibrillation. If you see irregular in a STEM, or you see it on an EKG, that is AFib. Okay, next part. What is the most likely etiology for this patient's condition? Remember, we had that older gentleman, he had sudden right arm weakness. All right, hopefully you got embolus. We know an embolus is something that travels and a thrombus is something that stays put. And this is often a point of confusion, especially as you're learning it. So just to be very clear, thrombus, a blood clot forms in place within a blood vessel. Our classic example for this, we're always worried about it in the hospital, is your DVT, or deep vein thrombosis, okay? That is in your leg, it is a clot and it is staying there. The second it travels to somewhere else, a clot or other material that travels somewhere else in the body and lodges in a blood vessel somewhere else blocking the flow, that is an embolus. So our DVT, we're concerned about becoming a pulmonary embolism. And then thinking about how this applies to atrial fibrillation, right? So when we have a situation of AFib, we have this really chaotic signal coming from the left atria usually. And what it does is it's just, loud ringing bells, ding, 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 in the irregular rhythm. And our AV node gets overwhelmed and it rets out these QRS complexes in different time periods. And what it means is that our flow is not synchronized. We don't have this beautiful contraction of the atria pushing the blood all at once into a ventricle, and then the ventricle is allowed to push that to the body. And so what happens when our electrical signal, which represents mechanical events, is not in one good unison, well-worked, oiled machine, is that we don't have good blood flow. And what do we know what happens when blood stays put? It clots. Here with this gentleman is we've got this dysynchronous, chaotic energy, this fibrillation going on in the atria. So we get this pooling of blood that's not moving anywhere. We have a clot that forms, and then that clot we call a thrombus until it is pushed out of the heart. And when it is pushed out of the heart on the left side, push from the left atria to the left ventricle, and then it shoots out into the body, it shoots up to the brain, and you get a stroke. And that's why we think about AFib. One of the biggest things we worry about it is actually stroke. All right, you have a 55-year-old woman with a history of hypertension presents with chest pain. What do you see? Now tell me, what is the rhythm and the diagnosis? Yeah, hopefully you got sinus rhythm with ST segment elevations and consistent with an acute ST elevation myocardial infarction or STEMI. Okay, let's go back and look at it, okay? So when you're approaching this EKG, I think one of the best ways, especially as a medical student going out there, is, focus on what your eyes are drawn to, and then make sure you know how to look at the whole picture so that you can figure it out if you need to. But especially when we're in an exam setting, what are your eyes drawn to first? And the first thing that I see when I look at this EKG is I see these massive ST elevations over here. Okay, so what I'm going to do first is I'm going to look and see if is there a pattern. Is it in certain leads and not others? Is there reciprocal changes? Hopefully that sounds familiar. In order to have a STEMI, we also want to see the reciprocal changes. Because if we have a STEMI everywhere, well, then we're thinking of different diagnoses, different differentials, right? And so here we've got a ST elevation in lead 2, lead 3, and AVF. We know this is a pattern. This is our inferior MI. We see reciprocal changes in lead 1 and AVL. Remember, that just means that this, if you were to flip it upside down, it would look like this. Okay, so we've got our reciprocal changes and our STEMI in these. Now, when we talk about a sinus rhythm, you can have a sinus rhythm and you can have a STEMI at the same time. They're different issues. A STEMI is related to our ischemia and infarction, and a sinus rhythm just means that you have this electrical signal that starts from the SA node. And we know that because we have P waves. If we didn't have a P wave, we wouldn't have a sinus rhythm. But we have a P wave, so they have a sinus rhythm, but they still have a STEMI. Yes, so now what is the most important immediate intervention? Yeah, hopefully you said emergent PCI or percutaneous coronary intervention. We look at the movies, we look at, if you hear it in the hospital, you have a code STEMI, okay? The most important thing to know is that the second that they enter the door of that hospital, we are going to try and get them to the cath lab so that we can look at the actual heart arteries and vessels, and we can say that's where the occlusion and that's where the blockage is, and we want to go in with a balloon, expand the balloon to restore flow. And then we might add a little stent to say, don't let that happen again. But I do also want to note that a lot of these other things listed in the answer are things that we also do in acute coronary syndrome. IV beta blockers are super important. That reduces the oxygen demand of the heart muscle and allows for more diastolic time. And we know, right, thinking it back, heart anatomy and things, right? So when we have an increase in diastole, we have an increase of the filling time of the ventricle, but also it's diastole that allows all the heart arteries to fill. We do give sublingual nitro. We do order echoes to assess wall motion. If you think about an infarction being a death of tissue, you're going to see that a part potentially of the wall of the heart, that heart muscle, might not pump in the same way as all the other working muscle of the heart. We can say and assess for wall motion abnormalities. And then absolutely we do start heparin, anticoagulant. Once a clot and occlusion is formed, you do not want it to keep going. And so heparin can help us with that. Stress testing sometimes is done in an inpatient setting, but I think most often you tend to see this outpatient. It's going to vary obviously a little bit hospital. The most important lesson there and most important reason why this is probably the not correct answer in this question is if your heart is already stressed because you're having an acute event, you're probably not going to want to go through further stress testing. You're going to want to figure out what's wrong so that you can have a plan. All right, you have a 22-year-old athlete collapses during a marathon. Still has a pulse. What do you see? All right, what's the rhythm? And hopefully you said ventricular tachycardia. All right, why is it this? Let's go back to the big one, okay? We see wide. Okay, we see wide QRS. These are like our R's here, right? And this is just squiggle. Okay, so wide QRS tells us what? Tells us it's coming from the ventricles. We have this massive signal coming from the ventricles. Our atria are not in the picture. All we have is this big tachy ventricle thing happening. And we see that they look the same and that the rhythm is pretty regular. We're not changing massively our pattern. I mean, yes, we have this, it looks different than this, but that's because they're in different leads, right? So that's where we look at our rhythm strip. So all of lead 2, these all look the same. So that's how we can say it's ventricular tachycardia as opposed to like torsade de pois or torsades. That is going to give us our ribbon shape. Our AFib with a rapid ventricular response or RVR could also give us a very fast heart rate, but we're going to see AFib, irregular rhythm, right? Our atrial flutter is a sawtooth pattern. This isn't a sawtooth, but again, it would have a QRS that's narrow, just like AFib, and this is not narrow, this is wide. And then supraventricular, supra, above the ventricles, that would be a narrow, so this is not narrow, so that is incorrect. So our only wide options here are actually ventricular tachycardia and torsade de poids. And then you just need to know that because these are monomorphically the same, that we're going to go with the VTAC as opposed to a ribbon. All right, what is the first line treatment for this arrhythmia in an unstable patient? Yeah, hopefully you said synchronized cardioversion. All right, so a little bit of lesson here. Ventricular tachycardia or VTAC with a pulse, you're going to use synchronized cardioversion. The pulse is important here. The goal is to stop the arrhythmia safely without inducing defib. So synchronized just means that the shock is going to be timed to the R wave on the EKG. And this is super important because what you don't want to have happen is a shock that happens during that vulnerable period of the T wave, which can then trigger VFib. So if you have a pulse and you can actually say that is where the beats are happening, and this is where the R is of each wave, then you can time the shock with the pulse and make sure that you deliver it at the appropriate time. Now, if you have a pulseless VTAC or a ventricular fibrillation already, then you go into unsynchronized defibrillation. You don't know where the pulse is. It doesn't matter. The patient's in cardiac arrest. Timing does not matter. You deliver a shock immediately to depolarize all of the cardiac cells and hopefully allow the normal pacemaker to reset. So big lesson here, pulse, synchronized, no pulse, defib. All right, you have a 70-year-old man with chronic kidney disease. He presents with muscle weakness. What do you see? What is suggested by the EKG? Hopefully you said hyperkalemia. First thing we see when we look across, hopefully, really tall T waves, right? Super peaked, high peaked T wave, hyperkalemia. It's always potassium, right? If we saw this was like low and then you had this little extra bump, that would be a U wave. That would be hypokalemia. So we know it's not that because we have high, tall, peaked. Now, hypercalcemia and hypocalcemia, I like to think about potassium is something that we see in the y-axis and calcium is something that we see in the x-axis. Remember, our EKG, we've got a y-axis up and down and x-axis side to side, just like you would see in a normal graph. High potassium, high on the y-axis, low potassium, low on the y-axis. High calcium, we're actually going to shorten the QT interval. So that, remember, QT is the start from the QRS complex all the way to the end of the T. So we'd see this distance shortened for hypercalcemia. And then if you have hypocalcemia, you're going to see a widening of that QT interval. What is the initial emergency management here? All right, hopefully you said administer IV calcium gluconate. And the reason for this is you want immediate cardiac membrane stabilization in severe hyperkalemia. There are other ways to manage high potassium. We can give insulin and glucose. Absolutely, insulin's going to pull that potassium into the cell. But the first thing that you always want to do is stabilize your cardiac membrane because hyperkalemia, if it's severe enough, can cause your heart to stop. And that's what we want to avoid. So we have to stabilize it first so that we can then treat the high potassium in other ways. 45-year-old woman presents with palpitations and anxiety. What do you see? All right, what's the rhythm? Yeah, hopefully you said this is a supraventricular tachycardia. Remember we talked about this like a couple slides ago, okay? If supraventricular means it's above the ventricles. And so we expect a narrow QRS and it's tachycardia, so we expect a very fast rate. Now the big difference between supraventricular tachycardia and sinus tachycardia is what? Can you visualize a P wave? And in this case, it is so fast and so smushed together that you cannot visualize a P wave. You cannot say that this wave here is distinctly a P wave, therefore supraventricular. It's just above the ventricles, okay? AFib, irregular. Do not forget a flutter, sawtooth, right? VTAC, ventricular, starts in the ventricles. That would be a wide QRS. And a multifocal atrial tachycardia. Multifocal just means the atrial beats are coming from different places, not just the SA node. And so we're going to have different morphology to our P waves, but we know that that's not what this is because we can't see any P waves. Okay? What bedside maneuver can be attempted first to terminate this arrhythmia? The Valsalva maneuver. So we increase parasympathetic or vagal tone, slow the conduction through the AV node. You also see carotid sinus massage can be used in these. Big thing here is you don't want to do both sides at the same time. Don't make yourself pass out. But again, it's increasing that vagal tone. All right, this is the end of part 1. We will pick up again part 2.